everyone. My name is Patrick Norman. I'm a UT Health Family Nurse Practitioner student and will be sharing a presentation on lumbar punctures. I will begin by introducing the lumbar puncture procedure and discussing some brief history of it. Next, I will share indications and contraindications for performing them. We will then move on to what equipment is needed and a step-by-step guide on how they are performed. Post-procedural care and complications to monitor for will follow. Finally, I will highlight normal CSF lab results and mention how nurse practitioners are compensated for the lumbar puncture procedure. So what is a lumbar puncture? A lumbar puncture is a medical procedure in which a thin, hollow needle is inserted into the lower part of the spinal cord to collect a sample of cerebrospinal fluid, abbreviated CSF. Well, what is CSF? CSF is an ultrafiltrate of plasma contained within the ventricles of the brain and the subarachnoid spaces of the cranium and spine. What does it do? Cerebrospinal fluid functions to provide nourishment, facilitate waste removal, and protect the brain. How much of it is there? The average healthy adult has a cerebrospinal fluid volume estimated to be 150 milliliters. Yet, the same adult produces 400 to 600 milliliters of cerebrospinal fluid all day. Well, that doesn't seem to add up. If 400 to 600 milliliters is made, but only 150 milliliters is present in the body at one time, how is this so? There is a constant recycling of cerebrospinal fluid. In fact, it replaces itself in totality 4 to 5 times in a 24-hour period. This turnover decreases as an individual ages. This turnover decrease may contribute to the accumulation of metabolites seen in aging and neurodegenerative diseases. Some historical context. The first reported lumbar puncture procedures were performed in the late 19th century by the German surgeon Heinrich Irenaeus Quincke. The name Heinrich Quincke may sound familiar. He was among the first to recognize angioedema, which is often referred to as Quincke's edema. His name is also associated with the redness and pallor seen underneath the fingernails termed Quincke's pulse as a sign of aortic insufficiency. Although an infrequently used term, one may hear the lumbar puncture referred to as a Quincke's puncture. British physician Walter Essex Winter began attempting the procedure to relieve pressure at around the same time. These early procedures were associated with a high mortality rate, however. In fact, all 4 patients Walter Winter performed the procedure on died. Today, approaches may be guided by fluoroscopy or ultrasound to improve success rates and reduce the incidence of trauma. Luckily, the procedure is relatively safe. Per a 2023 analysis of 525 Australian performed lumbar punctures, minor complications resulted from 8.6% of cases. The most common among these was a post-dural puncture headache. Major complications resulted from just 1.7% of cases. Indications for performing a lumbar puncture are either diagnostic or therapeutic in nature. Diagnostic lumbar punctures aim to measure intracranial pressure or sample the cerebrospinal fluid. Therapeutic lumbar punctures are done to relieve elevated intracranial pressure or to directly administer intrathecal medications. Specific examples of each indication can be found in the graphic on this slide. Lumbar punctures should not be done when patients present with increased intracranial pressure with associated mass effect, as this increases the risk for herniation, which can be fatal. They should also never be done over a superficial skin infection, as there is a chance of introducing foreign bacteria into the otherwise sterile intrathecal cavity, placing the individual at risk for devastating infection. Caution should be taken when performing a lumbar puncture in individuals with coagulopathy or thrombocytopenia. Coagulopathy is a condition of impaired clotting. This places individuals at a higher risk of uncontrolled bleeding. Similarly, although through a different mechanism, thrombocytopenia places individuals at a risk for inadequate clot formation at the puncture site due to a decreased platelet count. Spinal deformities require special precautions, as the normal anatomy is distorted, making it difficult to find the right anatomical puncture site. There is an increased risk of traumatic needle placement due to an unpredictable needle trajectory. This may lead to bleeding, nerve injury, or unsuccessful taps. Personal protective equipment needed for the lumbar puncture procedure are sterile gloves, a protective face shield, a surgical mask, and a gown. This not only helps protect the provider performing the procedure, but also helps to maintain a sterile environment to keep the patient safe. Much of the necessary equipment to perform a lumbar puncture will come together in a commercially available kit. These kits are sold to hospital organizations and clinic sites for providers to have readily available in a convenient package. What comes in the kits, however, is dependent upon each manufacturer. The materials on this slide may or may not come in each specific kit. Some examples of what is included include sterile drapes and towels. These protect the surgical site and the surrounding area. Antiseptic scrub, such as chlorhexidine, is used to disinfect the operative site before access. A 22 to 24 gauge spinal needle with stylet is used for spinal cord access. A Whittaker style needle is often preferred for its atraumatic nature. Lidocaine 1% without epinephrine is often used to numb the area as an anesthetic agent. A syringe and needle will also be needed to draw up and administer this medication. 4 numbered 3 to 5 milliliter cerebrospinal fluid collection vials are often included. These are used if the provider needs to take a cerebrospinal fluid specimen from the spinal tap. A manometer included in the kit is used to measure spinal fluid pressures. Finally, gauze and a bandage will be included to close and secure the puncture site upon removal of the needle to prevent foreign debris from entering the site. In preparing to perform a lumbar puncture procedure, it is important for providers to obtain and verify a signed patient consent form. Contents of this form should include an explanation of what this procedure is, why it is being done, what benefits stand to be gained, what risks are involved, and any alternative treatments they could choose. When having this discussion with patients, it is important to allow them to have enough time to ask any questions they may have. It is important to remember that undergoing such a procedure is a choice, and patients do have the right to refuse. In preparing to perform a lumbar puncture, providers should place patients into one of two positions, as illustrated on the slide below. Patients may be placed in the side-lying lateral recumbent position, as depicted on the left-hand side of this slide, or in an upright seated position while leaning forward, as depicted on the right-hand side of this slide. The correct anatomical puncture site is identified by locating the lumbar vertebrae. These are found in the patient's lower back. Providers should identify the third, fourth, and fifth lumbar vertebrae. Provider discretion is then used to determine whether the third and fourth lumbar vertebrae interspace or the L4 to L5 interspace will be more optimal for that specific procedure. Either one is an acceptable procedural site. It is paramount that the lumbar puncture be performed under a sterile environment. This helps to prevent infection, ensure an accurate CSF lab value result, protect patient safety, adhere to established clinical guidelines, and reduce legal risks for the provider. Cerebrospinal fluid is normally sterile. As providers, we do not want to harm the patient, so therefore, we should take special care to avoid introducing external threats to the intrathecal cavity capable of causing a devastating infection. Before using the spinal needle to access the intrathecal space, the provider should anesthetize the local site. This is typically done using lidocaine 1% without epinephrine. The provider should use a syringe and needle to draw up and insert the anesthetic. This is done by infiltrating the skin superficially and then advancing deeper into the tissue. This will help to alleviate any resulting pain caused by the lumbar puncture. When the patient has been properly anesthetized, the provider will then proceed with the lumbar puncture procedure. It's important to remember to advance the spinal needle slowly. Providers should take a midline approach with a slight cephalad angle at approximately 10 to 15 degrees towards the belly button. The provider should feel for a popping sensation. This indicates penetration of the ligamentum flavum and dura mater. The ligamentum flavum is a stretchy ligament between the bones of the spine. The dura mater is a tough protective layer around the spinal cord. After passing through it, you reach the space with spinal fluid. When in this intrathecal region, the provider should remove the stylet carefully, checking for cerebrospinal fluid flow. The provider should adjust if necessary, withdraw the needle slightly before redirecting to maintain sterility if a position adjustment is needed. When flow of cerebrospinal fluid is achieved, the provider should secure the needle to collect cerebrospinal fluid samples into the labeled sterile collection tubes. When enough cerebrospinal fluid sample has been collected in those tubes, the provider should place the stylet back into the spinal needle and slowly withdraw it from the patient's spinal cord. This informative video demonstrates how a lumbar puncture is performed.
Here's a video of demonstrating the lumbar puncture procedure.
On removal of the spinal needle from the spinal column, the provider should apply a sterile dressing over the puncture site. Alongside the nursing team, cerebrospinal fluid leak should be assessed. Healthcare professionals should check the site for any ongoing clear fluid drainage. It is important to recommend the patient lie flat for at least 1 hour post-procedure. It is also important to encourage the patient to consume adequate fluids. This may be done IV if the patient is unable to drink enough fluid to replace the cerebrospinal fluid removed. Both lying flat and maintaining adequate hydration following the procedure may potentially prevent post-lumbar puncture headache. Complications of the lumbar puncture include headache being the most common, infection, bleeding, and herniation, a rare but potentially deadly complication. A fact about headaches, as they are the most common, is that they typically begin within 24 hours upon completion of the procedure and often resolve by day 10. It is important to treat the patient for any symptomatic pain that is incurred in this time. An interpretation of normal cerebrospinal fluid results is below. The parameter, being on the left, is accompanied by its associated normal value on the right. I will give you a minute to review those characteristics and numbers at this time. Reimbursement. Nurse practitioners need to be compensated for the procedures they perform. Family nurse practitioners can perform and bill for lumbar puncture procedures using current procedural terminology codes. These are abbreviated CPT codes. If the lumbar puncture done was for diagnostic reasons, such as a collection of CSF for testing, then we would use the CPT code 62270. If a lumbar puncture is done using imaging, such as under fluoroscopy or with an ultrasound, another CPT code would be more appropriate. These procedures, however, are typically done by physicians. If the lumbar puncture was done for therapeutic purposes, CPT code 62272 would be utilized. This would be if the lumbar puncture was done for drainage of CSF or for injection of intrathecal medication. In conclusion, lumbar punctures are a critical diagnostic and therapeutic tool. Nurse practitioners can safely perform them to help their patients. It is important to practice, maintain sterility, and monitor patients post-procedure for any complications. This slide features the references I utilized for this presentation. I encourage you to visit each, as they contain lots of valuable information about the lumbar puncture procedure. I hope you learned something about the family nurse practitioner role in performing lumbar puncture procedures today. Thank you.